we move to Egyptian experience with Eman Professor Eman Sedhom and Children Cancer Hospital Egypt 10 years experience. Please, Dr. Eman.
First, I would like to thank the organizing committee and my dear colleague, Dr. Sheikh Fadel, for inviting me to share with you the 10 years CCHE, the Children Cancer Hospital Egypt experience in the minimal residual disease directed therapy in pediatric AML. This is our hospital for who did not see it. First, I would like just to show you the annual distribution, the ALL patients at our hospital since it started in 2007. In the first few years, we were recruiting more than 200 patients. Till the year 2014, we can see that we recruited more patients, more than 300, till the year 2016, and in the last 3 years, we are recruiting now more than 450 newly diagnosed ALL patients per year, and they represent around 19% of the malignant cases that we are treating at our hospital. We are adopting the Senju Total Study 15 for treating the newly diagnosed patients with ALL. It's a risk-directed therapy based mainly on minimal residual disease levels. We measure the MRD by flow cytometry after 2 weeks of induction therapy on day 15 or day 19 for those patients who received 4 days pre-phase steroids, and at the end of induction. This is following the risk stratification of Senju, that patients are classified as low risk if they are B precursor ALL having NCI standard risk for age and white blood cell count, and having favorable response with MRD day 15 less than 1%, and day 42, which is the end of induction, less than 0.01%. And these patients should not have CNA3 status or testicular involvement or any unfavorable genetic features. It's also worth noting that in this low-risk group, they also include, and we include, the NCI high risk for age and white blood cell count if they have favorable genetic features, translocation 1221, or a favorable DNA index, and having the same good response. These patients are treated on anti-metabolite-based therapy. High-risk patients were included if they have Philadelphia positive ALL, hypodiploidy less than 44 chromosomes, intrachromosomal amplification 21, and translocation 1719. However, in the last few years, we are not including all PCR-able ALL or hypodiploidy to be assigned for transplant if their response is adequate. Also, patients who had induction failure and MRD, high MRD at the end of induction at the level of 1%, or a persistent positive MRD on week 7 at the level of 0.1%, they were classified as high risk. For the remaining patients who did not meet the criteria for low or high risk group, they were classified as standard risk, and they were given intensive multi-agent chemotherapy. We had some amendments throughout these years. In January 2011, we amended the intrathecal chemotherapy according to the recommendations of the Total 16 protocol. In October 2011, we risk classified a fourth category as a very low risk patients, and these patients were treated on less intensified protocol. These very low risk patients were identified if they were provisionally low risk patients and had an MRD less than 0.01% on day 15. In March 2012, we added the translocation 1719 and intrachromosomal amplification 21 to the high-risk criteria. In May 2017, we modified the very low-risk criteria to include just the NCI standard risk for age and white blood cell count with favorable genetic features and negative MRD on day 15, and I will show you why we did that. We also modified the reinduction phase of the low risk to include anthracycline only in reinduction phase 1, and modify the duration of continuation therapy to 120 weeks for both boys and girls instead of 146 for boys. In my presentation, this is an analysis of a total 2,640 patients who were recruited in a 10-year period duration between July 2007 and end of June 2017. Their age ranged up to 18 years, but we do not include infant ALL in this category. 60% of the patients were males. 22% of patients had an age equals to or greater than 10 years. 1% were Down syndrome. And most of our patients were Egyptian, only 2% were non-Egyptian, mainly from Sudan, Yemen, and Syria. 14% of the patients had a very high white blood cell count at initial presentation. It was equals to or above 100,000. 20% of the patients had T-cell phenotype. Among the B precursor ALL, 64% were common ALL, 13% pre-B, and 4% pro-B. Among the T-cell subtypes, the most common were the T intermediate. Early T was 22% and late 4.3%. In this pie, actually the frequency of the ETPs appear a little bit lower, but the actual frequency of the ETP in our patients is 14% because we started just to diagnose this category from the year 2015. Among B precursor ALL, the favorable DNA index was found in 29% of the patients. Regarding their cytogenetic features, 35% of the patients were having high hyperdiploidy, and 1.3% had hypodiploidy. Translocation 1221 was found in 18% of the patients, 119 in 7%, Philadelphia positive ALL in 3%, MLL rearrangement in 1%, translocation 1719, it was only diagnosed in 4 patients, and all of them were either refractory or had very early relapse. Intrachromosomal amplification 21 in 1%. As we said, hypodiploidy in 1.3%. The favorable trisomies in 24%, and 31% of the patients had not otherwise specified genetic features. For the CNS status, 1% of the patients had positive CSF with blast, another 1.4% were traumatic with blast, and we had 10.8% traumatic without blast. I just want to highlight that in our patients we intensify the intrathecal therapy even for traumatic CSF without blast because we found higher CNS relapse even in this category of patients. So finally, we have like 2.4% of our patients categorized as CNS3 status. On the contrary of the Sanju, they have the problem there for overdiagnosing CNS2. Here we have the problem of underdiagnosing CNS2 patients. We only had one of our patients that's been diagnosed as CNS2. 54% were provisionally classified as low risk, and 40% of the patients were provisionally standard risk, and 4.5% were provisionally high risk. After seeing their MRD response, their final risk were 43% as low risk, of whom 10% followed the very low risk protocol. 47% were finally classified as standard risk and 9% as high risk. 94% of our patients achieved complete remission post-induction. We had 4% induction mortality and 1.5% failed to achieve remission post-induction. This is the MRD response on day 15. 33% of the patients had an MRD less than 0.01%, and 41% with an intermediate level of MRD, and 25% with an MRD equals to or greater than 1%. I'm sorry for it's being here, slipped the sign here, it looks like Arabic. So the MRD at the end of the induction for the whole patients, we had 83% of the patients less than 0.01%, and 4% of the patient had an MRD at the end of the induction equals to or greater than 1%. This is the MRD on day 15 in relation to the provisional risk groups. We can see that for provisional low-risk patients, 18% had MRD equals to or greater than 1% on day 15. This is compared to 34% for the provisionally standard risk and 36% for the provisionally high risk. At the end of induction, 10% of the provisionally low risk had intermediate MRD levels, and these patients were treated on the standard risk protocol. 1.2% had MRD equals to greater than 1%, and these patients were treated on the high risk arm. For the provisionally standard risk, 8% of the patients had high MRD at the end of induction, and these patients were treated on the high risk protocol. Out of the provisionally high-risk patients, 71% had negative MRD at the end of induction, and 6% had still high MRD, greater than or equals 1%. This is the final status of our patients with a median follow-up of 5 years. 75% are alive in continuous complete remission, 4% induction mortalities, 5% died in complete remission in CR, 12% relapse. We had only 0.3% second neoplasm, and it's worth stating that less than 1% of the patients abandoned treatment during their therapy. These were the site of relapse. Around 6% were hematologic relapse, 3.8% isolated CNS, 1.8% combined hematologic and CNS, very minimal relapses for testicular, and 0.3% for second neoplasm. The 5-year event-free survival of the whole patients is 74%. The 5-year relapse-free survival is 84%. And we can see the difference, that this difference was mainly due to toxic mortalities. The overall survival of the whole patients at 5 years was 79%. In relation to different risk groups, the 5-year event-free survival for the very low risk was 90%, 84% for the low risk, 69% for the standard, and 48% for the high risk. The 5-year relapse-free survival was about 93% for the very low risk, 90% for the low risk, 81% for the standard risk, and 63% for the high risk. And you can see that still the high risk group is not doing very well. This is, I assume that it's because only 15% of our patients were able to get transplant, because we transplant only from HLA match sibling donor. The overall survival at 5 years was 95% for the very low, 89% for the low, 73% for the standard, and 53% for the high risk group. As I mentioned, that we had a study on the very low risk group that was carried out between 2011 and 2015. We compared the survival of this study to the previous cohort of patients who had the same characteristics and the same MRD being less than 0.01% on day 15. We found that the cumulative incidence of toxic deaths was significantly lower in this study. It was 2.5% versus 7.5% in the earlier CCHE standard treatment protocol who were treated on the low-risk arm. The differences in the event-free survival and the cumulative incidence of relapse were not statistically significant. And the 5-year overall survival was 95% for the very low risk and versus 89% for the same cohort who were treated on the low risk arm in the earlier period, but this was not significant. The 5-year relapse-free survival of the B precursor ALL were better than the T cell. It was 85% versus 79% for the T cell. In the next few slides, I would like to show you the clinical impact of the MRD on the major ALL subtypes in our patients. The differences of the 5-year relapse-free survival among the B precursor ALL patients in relation to their MRD levels on day 15, it was found to be statistically significant. However, for the T cell ALL, it was not to be found to be significant. But it's obvious that we can see that here the MRD level greater than or equals 1% on day 15, their outcome was lower than the other levels in the T cell, as well as for the B cell. So further analyzing this group, we found that the T cell ALL actually who had an MRD level between 1 to 5% on day 15, their outcome was similar to the other MRD level, but the outcome was significantly poor if their MRD was at a level of 5% on day 15. While for the B precursor ALL, their outcome was poor at a cutoff of 1%. What about end of induction MRD levels for the B and the T cell? Both of them showed statistical significant differences in the relapse-free survival compared to the MRD levels at the end of induction. But also here we can see that the MRD levels at a level of 1% for the B precursor, they have much more worse outcome than the T cell at the level of 1% at the end of induction. And further analyzing this patient, it's also found that between level of 1 to 5% at the end of induction, they had a lower outcome than intermediate or negative MRD, but still acceptable. But for levels more than 5%, it was really very poor, the same as for the B precursor at the level of cutoff of 1%. What about this group who had an intermediate MRD level at the end of induction for the B precursor ALL? Actually, their relapse-free survival was less than the T cell who had the same MRD levels at the end of induction. So we were interested in this group to have further analysis. Further analyzing this group who had intermediate MRD level among the B precursors ALL, regarding to their provisional risk group. We found that the provisional low-risk group who had such an intermediate levels at the end of induction, they had an acceptable relapse-free survival being 81%. And just to remind you that these patients were upgraded and they were treated on the standard risk arm. While patients who were provisionally standard risk and had a detectable MRD between 0.01 and less than 1% at the end of induction, this patient had significantly poorer relapse-free survival. And you can see that it's even very poor outcome at a level of 0.1% at the end of induction. What about adolescents? In this analysis, we considered the adolescents at an age of 13 years and above, and we compared the relapse-free survival for the adolescents versus the younger group if they have MRD level less than 0.01% at the end of induction, and actually the relapse-free survival were comparable. But if adolescents had an MRD detected between 0.01 and 1% at the end of induction, their outcome is extremely poor compared to the younger groups having the same MRD level at the end of induction. This slide shows you the outcome of the patients who were NCI high risk by age and white blood cell count, and they had favorable genetic features as well as early responders, and they were treated on the low-risk arm. So these patients are presented here by the blue line, and the green line are for the other patients who were NCI standard risk for age and white blood cell count and were treated on the low-risk arm. The 5-year relapse-free survival was comparable, even it was a little bit higher for the NCI high risk for those treated on the low-risk arm. The same for the 5-year event-free survival. They were very comparable results, and these were encouraging that such escalation of therapy for these patients was successful. This last few slides were just to summarize the relapse-free survival among different ALL subtypes in relation to the MRD day 15 as well as end of induction. The first table here is for the provisional low-risk patients. We can see that for patients having translocation 1221 and high hyperdiploidy, they have the most excellent outcome with a relapse-free survival of 93 and 95% if their MRD on day 15 is less than 0.01%. They have also very good outcomes if the MRD is negative by end of induction. But at the higher levels of MRD, it was significantly lower relapse-free survival rates, and very lower relapse-free survival if the MRD was high at end of induction. But can you see these numbers? What about other NCI standard risk BLL who did not have the favorable genetic features and they had MRD negative on day 15? Their 5-year relapse-free survival looked much lower than those having favorable genetic features despite of having MRD negative on day 15. So this is the reason why we were considered about classifying the very low risk. Should we classify all patients with the NCI standard risk who had the MRD on day 15 less than 0.01 as very low risk, or just those having favorable genetic features? In this comparison, we analyzed the patients before starting the very low risk patients at the very low risk study. This column were for the NCI standard risk for age and white blood cell count having favorable genetic features and MRD negative on day 15 versus the NCI standard risk for age and negative for favorable genetic features and negative MRD on day 15, and both group of patients were treated on the low risk arm. We found that the relapse-free survival was significantly lower than those with the favorable genetic features. However, when we analyzed our very low risk study, which included also both groups in this study till 2015, we did not find the difference in relapse-free survival. For the provisional standard risk ALL, we discussed already the T cell. For the translocation 119, we can see that they have an excellent outcome if their MRD is less than 0.01 on day 15. But just to remind you that these patients are treated on the standard risk arm, not on the low risk arm, as well as they have a good outcome if their MRD at end of induction was negative, and they had a really poor outcome if it was detected at any level post-induction. The same for the NCI high risk for age and white blood cell count. If the MRD was detected at end of induction, they have very poor outcome. Finally, the high-risk group here, the interchromosomal amplification 21, had an acceptable outcome if their MRD was negative at the end of induction. Unfortunately, some of these patients were treated on low-risk arm because we screened them retrospectively for such genetic abnormality. Since, as we said, since we started to include them in the risk stratification, all of them receive intensive chemotherapy, but we do not transplant patients who have negative MRD by end of induction. For any level positive at end of induction, they have much significantly poorer outcome. Astonishingly, that our hypodiploid patients do not do very well if their MRD was negative at end of induction, and most of them did not receive transplant. However, the 75%, the relapse-free survival was 75% at 5 years if their MRD was negative on day 15. The Philadelphia positive ALL had a very good outcome with the addition of TKIs without transplant if they have a negative MRD at end of induction, but very poor outcome if their MRD was positive. So in conclusion, all attempts should be made to reduce toxic mortalities, and this warrants cautious with increasing indications for more intensified therapy. MRD-directed therapy allowed children with low-risk ALL to achieve good outcome with modest therapy and to be spared more intensive and toxic treatment. Also, it increased the chance of cure for provisionally low-risk patients who were upgraded to the standard risk arm based on their MRD response. Moreover, the therapy was successfully de-escalated based on favorable genetic features and negative end of induction MRD, irrespective of age and white blood cell count at presentation. Patients with ATP6 RUNX1 fusion gene or high hyperdiploidy had the best prognosis, especially those with a negative MRD on day 15, had a particularly low risk of relapse in whom further de-escalation of therapy can be considered, especially in low middle income countries, to help reducing therapy-related morbidities and mortalities. B precursor ALL patients classified as provisionally intermediate risk have significantly lower relapse-free survival if their MRD was detectable at any level at the end of induction. Outcome of B precursor ALL patients was poor if MRD on day 15 was equal to or greater than 1%, while T-cell ALL had poor outcome if the MRD was equal to or greater than 5%. Novel approaches should be considered for these subgroups. Actually, for the B precursor with such responses, may be considered for diagnosing Philadelphia-like ALL. As well, you may consider immunotherapy and CAR T-cell for such patients. While for the T-cell, maybe nelarapine would improve outcome for such slow responders. Hypodiploid ALL patients with negative MRD on day 15 can be treated with intensive chemotherapy alone, while patients with MRD equals to or greater than 0.01% on day 15 may be better treated as high risk for other options and other alternative therapies. Philadelphia positive ALL patients with end of induction MRD less than 0.01% and adequate molecular response by week 7 can be treated as standard risk, while those having detectable MRD by flow cytometry at end of induction should be classified as high risk and to be assigned for transplant. So finally, MRD constitutes the single most important prognostic indicator in ALL. MRD levels during remission induction treatment have important prognostic and therapeutic implications, even in the context of MRD-guided therapy. Further refinement of risk-directed therapy based on MRD levels and leukemia subtypes may increase ALL cure rates even higher. I would like to thank each member of the ALL study team at our hospital, and thank you for your attention.
Now the floor is open for any discussion or comment for Dr. Eman.
First off, I wanted to congratulate you for those really outstanding results. Then a question and a suggestion. So my question is what you're doing to keep the abandonment rates so low, because they're impressively low. And the suggestion is that you are ready to conduct randomized clinical trials, and what questions do you think you should ask?
For the first, for keeping such low abandonment rates, we keep following the patient. If the patient misses kind of an appointment, we actually call them and we try to see if they have any problem for coming, or so we are following with the patients if they actually miss 1 or 2 appointments, and then this would keep them more with a better abandonment. Besides that, with better education for the parents, that sticking to the to the chemotherapy and to the protocol would much reflect on their outcome. They are actually now more keen to follow the protocol on time. What's for next question? Starting randomized trial?
Yes, I think you're ready to conduct randomized trials. And
yeah, we are hoping actually to start this. Yeah, we're eager to begin that.
Any other comments?
Thank you.
Thanks, Dr. Eman.